Thank you very much, Mike. It's very interesting to be in a session with Shami Chakrabarti and Nick Ross. I'm not quite sure how the flow works here, but I want to start by thanking the organisers for inviting me to be with you all here today and giving me the opportunity to share some of my perspectives with you. I want to start actually with reflecting on the theme of the conference, Expanding Horizons of Care, because of course it's particularly relevant for cancer as we think about where we are with cancer. Indeed, our horizons in cancer are not only expanding, they're really changing quite dramatically at the moment. Historically, when we've talked about new horizons in cancer, we've tended to emphasize new treatments, new technologies, how we can treat disease, cure patients, and so on. But the agenda is evolving, and it's evolving quite fast in a way that we need to give far greater emphasis to prevention, to early diagnosis, to the experience that patients receive, and in the case of cancer, to living with and beyond the disease. And with this change of emphasis comes a greatly expanded role for primary care, which challenges everyone in this room to think about your role and how we address that role going forward. So my sort of summary today, the messages I want to leave you with are the cancer burden in society has increased hugely. It's going to continue to increase. The role that you will all play in primary care is becoming ever more pivotal, and I'll explore some of those areas. And although we fully recognise that we have significant capacity pressures, not just in primary care, but throughout the NHS, nevertheless, there are things we can do and we need to start doing them. Now, we have to do all of this in a high-quality, safe, patient-centred pathway, but it is possible to do so. So I'm going to talk about various aspects of the work that we've been doing. I will talk about the cancer strategy, which of course was developed for England, but many of the themes in that strategy are relevant to Scotland, Wales and Northern Ireland as well. And some of the data I'll use will be UK and some of it will be England, but again, the messages will be very much the same. Now the great news is you get two shots at cancer today, because later in the afternoon you're going to be hearing from Greg Rubin, who's going to be introducing this report published this week. I believe you all have a copy in your conference bags. I'm sure you've read every word of it. And if you have done, you'll know that Greg will be talking about some similar messages to the ones that I'm going to be talking about. So my focus is going to be on thinking about how the role of primary care in cancer is expanding, the specific challenges facing us as a population, as a system, and indeed an individual perspective. I'll talk about what needs to change and how it needs to change, and I'll give some insight into some of the work that Cancer Research UK is doing with primary care, indeed working closely with the college and others to support this. So what's the challenge, first of all? Well, let's start with the policy context. In England, we've had the publication of the 5-year forward view, which places a strong emphasis on prevention, on patient empowerment, on new models of care. In July of this year, the Independent Cancer Task Force, which I had the privilege of chairing, which had Maureen Baker on it and many others, we published our report setting out how cancer services could be improved, as I say, in England, but with many themes that will be relevant to the other countries of the UK. These are strategies that lay out a vision, lay out a framework, and indeed lay out a plan of action for what we need to do next. But specifically, what does it mean for primary care? So I'm going to start with some statistics, some of which some of you may know, some of you may not be as familiar with them. And I'm going to start with the incidence of cancer and the fact that now in the UK, half of your patients in your practices will be diagnosed with cancer at some point in their lifetimes. This is a number that's been growing. We've always known it would get to 1 in 2. We didn't quite expect it would get there as fast as it has, but we are now at that point. In fact, the data is for anyone born since 1960. But given that the vast majority of the population has been born since 1960, that it will affect 1 in 2 of the population. And as you can see from this chart, that number is growing and it's continuing to grow. The primary driver for this, of course, is age, but it's not just age. It's also about our lifestyles, and age standardized risks are also continuing to grow. Across the UK, this means that we have about 330,000 new cases diagnosed every year at the moment. That number is rising, and it's rising by about 2% every year. Now, in reality, what this means in the context of a primary care practice is that the number of new cases you will see every year is about the same as the number of new cases of diabetes. It's about double the number of new cases of stroke. But of course, what adds complexity to the picture around cancer is its heterogeneity. There isn't one type of cancer. There are many, many, many hundreds of different types of cancer. And certainly for the rarer types, you may only see 1 or 2 cases in your lifetime as a GP. There is, of course, good news. Mortality is coming down. Deaths due to cancer are decreasing as we find more effective treatments, as we get better at treating cancer at an earlier stage. And if we look at the most recent survival data, more than half of people now receiving a cancer diagnosis will live for 10 years or more following that diagnosis. Looked at another way, median survival in the 1970s from cancer was just 1 year. As little as 5 years, as recently as 2005, it was 5 years. Median survival is now 10 years. So we are seeing a real acceleration of progress here, and it's exciting. It's exciting to know that we really are making progress against this set of diseases we call cancer. But median survival means that 50% of patients are not reaching that point, and that means that in the UK, 160,000 people are still dying from cancer every year. And we know, and it's been very well trailed, that survival rates in the UK are not as good as they are in many other countries of similar wealth. We have in the UK amongst the lowest rates of incidence of cancer, but we have amongst the highest rates of mortality in rich countries. We know that that's primarily due to 2 things. One, that we have more advanced disease at the stage of diagnosis, at the point of diagnosis, than in comparable countries. And secondly, we have suboptimal access to care, particularly for patients with more advanced disease. So these are the 2 things that are driving this, the survival deficit that we have in this country. Cancer is now the leading cause of death from illness or disease in every age group, from the very youngest children to the very elderly. And it's therefore the biggest contributor to the loss of premature life years. In 2011, which is the latest data we have, more than a quarter of all deaths, in fact about 29% of all deaths, were caused by cancer in the UK. Now, of course, these data that I'm giving you are for the population as a whole, and there's a variety of factors that make the picture somewhat different in different parts of the country, or different age groups, or different socioeconomic backgrounds. And using data from England, we've been able to estimate that that there are about 15,000 to 20,000 more cases and deaths every year across all cancers in the more socioeconomically deprived groups. In other words, if we had levels of deprivation as good as the least deprived in the country, we would save that number of lives and cases every year. More than half of that differential is caused by different patterns of smoking. So smoking remains a very significant factor in socioeconomic inequity in cancer. Now, the other side of the picture is as we get better at treating cancer, so we have many, many more people who've had cancer at some point. And so the challenges that arise as patients live with and beyond their treatment become ever more important. Currently in England, we have about 2 million people who have had cancer. That's about 2.2 million across the UK, and that's projected to rise to about 3.4 million, or indeed 4 million for the UK as a whole, by 2030. So by 2030, roughly 100 patients for every GP will have had a diagnosis of cancer at some point. It's a pretty significant number of your patient population. So those are the stats, but of course the challenges we face also relate to the systems in which we're trying to deliver health services to our patients. Of course, we have finite resources, finite funds available. Of course, we have very significant workforce challenges, both within and beyond primary care, as I've already touched on. And these have a significant impact on our ability to deliver the sorts of care, the sorts of services we want to be able to deliver. But they are, nevertheless, challenges we have to try and address. And as we think about the stats and as we think about the system issues, of course, our day-to-day challenge is to think about every individual patient and making sure that the patients and those close to them receive, during their experience of cancer, their experience of diagnosis, of treatment, of follow-up, an experience that's seamless, that's joined up, that's personalized to their needs, that takes into account patient choice, that takes a whole person approach. And these are not things that we can always say we universally deliver for every patient across the country. So, what needs to change? What are the challenges that we need to address in these various areas that we've talked about, and how does this relate to the challenge for primary care? Well, as Mike said, in July we published in England the latest cancer strategy, and we identified the 6 strategic priorities that we think need to be taken forward. And by the way, what we set out was that if we are able to deliver against these priorities, our estimate is that we could be saving something of the order of 30,000 additional lives every year in England by 2020. These are huge, huge numbers. And that's, of course, as I say, just the England number. What we've developed is a robust and ambitious plan for cancer over the next 5 years. We are delighted that the strategy has been adopted by the various NHS bodies, by the government, by the Department of Health, and indeed, as some of you will have seen just a few weeks ago, the Department of Health in England set forth its plans to take forward some of the first sets of recommendations. I'm going to talk through some of these priorities in a bit more detail, but you can read what they all are, and you can read the strategy if you'd like to. It's available on the website. So first and foremost, prevention. It has to be our starting point. We know that around 4 in 10 of all cases of cancer are caused by aspects of our lifestyles that we have the ability to do something about: smoking, weight, physical activity, alcohol, and so on. And it goes without saying that your role in primary care is paramount here in encouraging healthy lifestyles and behaviours. That's not new, but as health policies focus increasingly on the benefits of prevention, and as further evidence emerges on how we can modify those risk factors, then that role is going to expand. Now, obviously, we need to keep going on smoking. It's the biggest single thing we can do, and we set out in the strategy that we think we should be aiming at getting adult smoking rates down to below 13% by 2020. It's ambitious, but it is achievable. But we also need to start giving serious attention to obesity, and we recommended that we really need to have a national action plan on obesity. Everyone in this room will know that we have dangerously high levels of obesity and overweight in kids, and we're building up huge problems for the future in cancer and a whole host of other diseases if we don't do something about it. Of course, we need to think in each local area about the social determinants of health and what we can do about those. And GPs have, of course, a huge role to play in helping individuals to understand these impacts, the impact of obesity, of smoking, of exercise, of alcohol in health. And frankly, we know that people are really afraid of cancer, but not many people associate obesity or alcohol with cancer. So use cancer as something that people should be thinking about when they're thinking about the importance of addressing obesity. Now, there's also more we can be doing in terms of chemo prevention. The use of tamoxifen and aromatase inhibitors for breast cancer, or for women who are at high risk of breast cancer, or aspirin for people who are at high risk of who have Lynch syndrome. These are well evidenced interventions, and we know that they could have a huge impact on rates of disease rates of cancer diagnoses, but they're not used systematically, routinely, perhaps in the way they should be. So a lot more to do on prevention. The second huge area is on achieving earlier diagnosis, and any of you who know me know this is something that I feel very passionately about. The strategy, the task force recommendation and estimate was that if we address earlier diagnosis in England, we could be saving about 11,000 lives every year. But we know that across the country, and of course, again, these data are for England, but the pattern is mirrored in the other nations. We know that there's a very differential outcome in terms of the proportion of patients who are diagnosed with early stage disease in different parts of the country. And that differential is not simply correlated with deprivation. So we know, for example, in bowel cancer, there's nearly a 3-fold variation in patients being diagnosed early when comparing the highest and lowest performing areas. In lung cancer, it's nearly 4-fold. In ovarian cancer, it's 5-fold. So we know that there's a huge amount more we can do better, even within the current system. And we also know that early diagnosis is not just about improving outcomes, although it does fantastically improve outcomes if we're able to get earlier stage diagnosis. It's also highly cost effective. We know that it's about 3 to 4 times as expensive to treat a later stage cancer patient as it is to treat an early stage cancer patient. And it's very cost effective. It's not cost saving, but it's very cost effective. Far more cost effective than the sorts of treatments we're developing to treat late stage disease. So it's not only about improving survival rates, it's also about using our resources much more efficiently. Now, late stage diagnosis is due to a large number of factors. These are some of them, and I don't have time to talk through them all, but they'll be very familiar to you, and there are things we can do in each area. Now, a diagnosis of cancer can be made through 2 primary routes. It can be through screening, or it can be through investigation of signs of symptoms. Screening gets a lot of attention, but it's actually only responsible for diagnosing about 5% of all cancers. Nevertheless, it is important. And of course, we have the 3 population-based cancer screening programs in the UK in bowel, breast, and cervical. And we know there's a large variation in the uptake of these different screening programs, and that primary care can play a role in that. Now, your role in terms of cervical screening and breast screening is very well established, but at least in England, GPs have had a fairly peripheral role in the bowel screening program. And one of the things that we've been recommending is that GPs should have a greater role to play in the bowel screening program. And we've set an ambition that we want to see around 75% uptake of bowel screening within the next 5 years, because we know that could save thousands of lives every year. And we have evidence to support this. A study that we've carried out through Cancer Research UK has shown that a simple letter of endorsement from an individual's GP coupled with an information leaflet did increase participation in bowel screening by 10%. So a relatively simple intervention with the involvement of a GP can really make a difference. Now, of course, we can't talk about screening without acknowledging the debate around overdiagnosis. I don't have time to talk in very much detail about overdiagnosis today, but what it absolutely drives us to is the importance of adequate information, and specifically balanced information on the benefits and the potential harms of screening as we grapple with this concept of overdiagnosis. We cannot as yet distinguish between an aggressive breast cancer and one that won't do any harm to a woman in her lifetime. So we're not yet at that point where we're able to do that scientifically. We will be at some point, but we're not there yet. But what is clear is that primary care can play a significant role in helping patients understand these concepts, ensuring that decisions are truly informed and not overtly influenced by whatever is the current media story. Now, even with screening programs in place, the great majority of patients, as I've already touched on, are diagnosed with cancer with patients who present with symptoms. And this, of course, includes patients who present to their GPs, but also those who are presenting through an emergency presentation. And around a fifth of all patients diagnosed with cancer are through an emergency presentation. And we know that these patients have very much poorer outcomes than those who are diagnosed through other routes. The good news is that the emergency presentation rate is coming down in terms of diagnoses, but it's still about a fifth of all patients. This good news, the fact that it's come down from about 24% to about 20%, owes a huge amount to some of the work that many of you in this room have been doing over the last several years since we first uncovered this a few years ago. So well done to you all for achieving this. But we know we've got a very much greater way to go as these figures represent. We also know that investigation of signs and symptoms is an area where there's huge scope for improvement. We have international evidence that shows that we consistently take longer to refer for investigation, and we refer fewer people for investigation in the UK as compared with most other countries. And indeed, we do much less. These are rates of colonoscopy, and you can see, well, I don't need to speak to this picture really, it's self-explanatory. This lower level of investigation and the lower readiness to investigate needs to be addressed if we're to really improve our survival rates through improving earlier diagnosis. It's absolutely vital that GPs have the appropriate tools at their disposal, that they have a supportive environment for referring, and that they have access to timely and high-quality services for diagnostic investigation. So we have to address the diagnostic capacity, but we also have to be willing to refer. And in England, one of the things that will help this is the new NICE guidelines for referral for suspected cancer, which reduces the threshold for investigation from what has been around 5 to 10% threshold of suspicion to around 3%. For some types of cancer, it may even be lower. Now, you're going to hear tomorrow about the research paper of the year, which actually says that if you ask the public what their level of suspicion would be before they'd like to see a referral for investigation, it's more like 1%. So even this 3% doesn't get us close to where the public feels it should be. Nevertheless, if we're able to get to this level, it would be a huge improvement from where we are today. These guidelines need to work hand in hand with strategies to address diagnostic capacity, and we've set out a number of things that need to be done to do this. But we absolutely have to put early diagnosis at the forefront of cancer control. We also need to give GPs much faster direct access to investigative tests. We have a far poorer level of direct access in the UK than in most other comparable countries. Now, if we do this, this should really help you as GPs. We know that many patients are coming to see you time after time after time with a symptom that they're worried about. Most patients are referred on the first or second visit, but around a quarter of all patients are coming to see their GP 3 or more times before they're referred for an investigation. And of course, there then may be many more visits before a diagnosis is confirmed. So there is an opportunity, if we get this right, to hugely reduce the burden on you. And one of the things that we've recommended to bring all of this together is that we set an ambition that the vast majority of patients should receive a definitive diagnosis or cancer exclusion within 4 weeks. And once we get to this point, we can probably do away with a 2-week urgent referral pathway. This should not be beyond our reach. We should be able to do this. And I'm delighted that the government has said that it's committed to introducing this and investing in additional diagnostic capacity and workforce over the coming years. Currently, around 22% of all patients report that it takes more than 3 months before, when they first go and see their GP with a symptom, to first seeing a hospital doctor, which, by the way, is, of course, not even a diagnosis. 8% of patients say it takes longer than 6 months. So we really do need to address this. Now, there are other things, of course, we can do to address earlier diagnosis, auditing. As we implement the 28-day standard, one of the things that we expect to emerge is systems that will help collect data that will also help with safety netting. And we've also recommended significant event analysis, particularly for those patients who are diagnosed through an emergency. And I know there's been some question about this, but actually, if you work out the numbers, on average, a GP will have 1 to 2 patients a year diagnosed through an emergency presentation. So I don't think this will be a huge burden. It is a huge opportunity to learn. Now, we also need to do a great deal to improve the patient experience, and we've talked about how we need to revolutionize the way we communicate with and the information we provide to cancer patients. This includes work around the doctor-patient relationship, but also around the use of digital technologies. The good news is overall patient experience is pretty good, but it is highly variable in different geographies, by cancer type, by age, by ethnic group, and so on. And primary care will continue to play a significant role in providing information and support and coordinating care for people with cancer and their families. Now, as I said earlier, as more and more patients survive, there is a greater number of patients who are living with and beyond cancer. And this is a cohort of people who have an increased risk of recurrence, an increased risk of being diagnosed with another cancer, some cases long-term physical and psychosocial effects, and we need to deal with all of these. And there are a number of things that we can be doing, and the task force focused on a set of priorities. For example, that every patient should have access to a personalized recovery package, that we need to think about prevention of recurrence, and here the role that primary care can play in advising patients to use exercise, because we know it reduces the risk of recurrence, and indeed adjuvant treatment, better stratifying follow-up pathways so that we use resources more efficiently and concentrate those resources on the patients who really need it. And indeed, we want to develop a new metric that looks at long-term quality of life. And we also want to do a great deal more about end-of-life care. Around 4 patients for every GP will die of cancer every year. And you will all know about the role of primary care in palliative care and end-of-life care. And this is an area that will continue to need attention. As will the whole area of integration of care, which is really fundamental. Most patients, as they go through their cancer journey, will not just interface with primary care, but will interface with a whole range of secondary and tertiary care providers. The transitions between those are very problematic in many cases. We have fragmentation, we have poor coordination, and that affects outcomes, and it clearly affects patient experience. So how we integrate primary, secondary, community care, specialist care is going to be essential as we move forward. And one of the things, therefore, that we've talked about is the development of cancer alliances that would bring together at a local level primary care, secondary care and tertiary care providers and cancer patients to really think about how we can integrate pathways, how we can deal with those transition points, and how we can deliver, for example, that 28-day standard. And practice nurses have a critical role to play here as well in terms of how you can help to coordinate care for individual patients. I'm conscious of time and I'm running a bit over, so I'm just going to very quickly talk about some of the areas that, in addition to what the government and the NHS bodies need to do, that Cancer Research UK and indeed the college are doing in some of these areas. So within Cancer Research UK, our focus has been on supporting and influencing locally relevant quality improvement initiatives at regional and local levels. We have an army of facilitators who go out and talk to practices about reflection about their local data and how that data suggests quality improvement opportunities. We've been funding strategic GP leads in strategic clinical networks to support priority areas of activity. We've been developing evidence-based tools and resources to support best practice and we've been developing educational modules and resources to improve knowledge and skills in priority areas. We're also driving what's known as the ACE program, which is looking at a number of different ways that we might be able to improve the diagnostic pathway through pilot initiatives that will be properly evaluated and then hopefully used to drive improvement. I want to briefly touch on the National Audit of Cancer Diagnosis in Primary Care. The last audit that was carried out was in 2010, and it gave us a huge wealth of information about current practice and about opportunities for improvement. We're about to launch, in partnership with the RCGP and others, the next audit, which will focus on data from 2014, will involve more than 1,000 practices, and we hope will give us a huge bunch more lessons that we can use in the years ahead. And finally, education, where we've been involved in a number of educational activities, some of which are in partnership with the college or with other bodies, e-learning modules, blended learning programs, for example, with the Royal Marsden Hospital. And through our partnership with the college, we're also running regional cascade workshops, and we're planning a series of faculty workshops in collaboration with other health charities. And Greg may talk more about training a little bit later on. I want to just finish before summarising with the story of someone who wrote to me late last year. Her name is Sally. As you might expect, I receive many hundreds of letters from patients every year about their cancer experience. She wrote to me late last year to tell me her story. She had had blood in her urine for a number of weeks and was obviously concerned about it. Sadly, it took her 10 days to get an appointment with her GP, but once she had had that appointment, she was put on to an urgent referral. She wrote to me with a 5-page letter, which was a litany of mismanagement, of poor communication, but actually written in a very witty style for someone who'd experienced such poor quality care. She wrote to me 5 months after she'd first seen her GP. She'd had 7 appointments with her GP in that time, and she still hadn't had a cystoscopy. At the end of that period of 5 months, she finally decided to have a cystoscopy privately, at which point she had a diagnosis of bladder cancer. And I'm going to quote the very last line in her letter as she wrote to me at this 5-month point. This is her language. Watch this space. 5 months have passed. Consider anticipatory phone call to local undertaker to arrange funeral. Decide I can afford to take my time. Phone calls to undertakers usually result in same-day service, which is an improvement on the NHS. I wrote to her earlier this year to find out what had happened. She's had treatment for her bladder cancer. We think the treatment's been successful, but she continues to be horrified, not surprisingly, by the experience she has had. I sent her letter to a number of people across a number of different organisations, and in every case the response I got was that they knew of someone who'd had a similar story. We have to do better. We can do better. We know we can do better. So, the cancer burden in society is increasingly significant. It will continue to increase. Your role in primary care is hugely important. It's becoming ever more important. I've only been able to touch on some of the things today that are going to be important in primary care as we look forward. Obviously, the sorts of things I've been talking about won't just be relevant to cancer, they'll be relevant to a whole host of other conditions that your patients will be experiencing. But as you think about addressing these challenges, I'd ask you each to think about what can you do, what can primary care do as a discipline, what else can we draw on, what else do you need to know that will help you? Thank you very much.